Hello again, everybody. It's Jim Henry. I appreciate the opportunity to talk to you now about Tinnitus Stepped-Care, a proposed model to standardize tinnitus clinical services. So, in my intro talk, I gave a background on different methods of treatment that have been used in the past, current methods, future methods, and so this is a little bit of a continuation of that, and it's what I am proposing we can do to address the issue of lack of standardization between different clinics, clinicians, researchers. So the following concerns frame all the contents of this particular lecture. There are no official standards for clinical management of tinnitus. That's the basic problem. Recommendations have been published as clinical practice guidelines. There have been lots of those published in Europe, United States, Japan. There's a lot of guidelines. They've been reviewed. The guidelines are fairly consistent in what they recommend, but they are inconsistently adhered to. So they're not really doing a lot of good. Any clinician can claim to be a tinnitus expert. That's unfortunate because there's so many clinicians claiming to be a tinnitus expert and they really are not competent. And I don't know who you are out there, but hopefully you have a high degree of competency and you're providing excellent services for your patients. That's all that really matters. So there's no credentialing program, and we need a credentialing program to ensure competency of tinnitus clinicians. And then finally, there's lots of progress, but in my estimation, there are no breakthroughs since the 1970s. So what Vernon and his group were doing with their masking method, sound therapy, and counseling, I cannot say that I've seen anything work any better than what they did. Now, they were extremely competent in what they did. They were very compassionate. They really worked hard with their patients. They spent lots of time with them. And they developed this combination of sound therapy and counseling that has been a model, kind of, for a lot of additional methods. Sound therapy and counseling, sound therapy and counseling. They seem to work well as long as you're providing the patient with good information, accurate information, helpful information, and using some form of sound therapy. And there are many different forms of sound therapy. We don't know that one method works better than any other. So we don't have a cure. All we can do is treat the behavioral effects of tinnitus: sleep problems, concentration problems, emotional difficulties, reactions to tinnitus. And we have lots of methods to do that. We can do it well, but we cannot say that any one method is proven to work any better than any other method. So here's what I'm proposing. I developed this recently. I have a publication in the works to publish this whole concept, and I'm also going to be writing a book. And Plural Publishing has already agreed to publish it, and it will go into all the detail. But for now, I'm just going to give an overview of Tinnitus Stepped-Care. Now, I will say this looks very daunting at first. Stepped care means we're stepping patients through higher and higher levels of services depending on their need. Some patients only need step 1. Some patients need all the way to step 6, just depending on how bothered they are by their tinnitus and how stubborn their tinnitus is to being treated effectively. And when I say treat their tinnitus, I'm talking about treating their reactions to their tinnitus, the effects of their tinnitus on their life. We're not treating the tinnitus itself. We're not treating the sound of tinnitus. We're treating the effects of tinnitus. So this is a framework. It's based on progressive tinnitus management, which is a 5-level stepped care method of treatment, but it includes specific procedures, especially at levels 2 and 3. Those are the really critical levels for PTM: the evaluation level, the treatment level. Basic evaluation, basic treatment. That takes care of most people. And with PTM, we have very specific ways of doing that. Tinnitus Stepped-Care is based on the model, but instead of instead of suggesting or recommending or even dictating specific procedures, Tinnitus Stepped-Care deals with concepts and principles of treatment. So if you're doing TRT, TAT, CBT, any of these other methods, you can do it within this framework. That's the concept, is to just know what the principles are at these different steps, to work within a stepped care model, but to do whatever you're doing in your clinic. You're a competent clinician, you're providing good services. This is proposing a standardized model for how to fit those procedures into a framework, a stepped care framework. So we'll go through it step by step. Step 1, triage, getting patients to the right provider to begin with. What kind of symptoms do they have? Who should they see? So there are different options, usually ENT, otolaryngology, mental health, emergency care, audiology. If nothing else, clinicians, any hospital, any provider, any physician should know that if a person complains of tinnitus and they really have tinnitus and it's not just some temporary ear noise or spontaneous transient ear noise, and they really have tinnitus, they most likely have hearing loss, and they should have their hearing evaluated by an audiologist. And the audiologist can also assess them for tinnitus, and do they have a problem with tinnitus, and also do they need to be referred. So we can look at specific guidelines, which we've created a tinnitus referral guide. This could be handed to any clinician, any provider, anywhere. And if they have a patient complaining of tinnitus, they can just look at the symptoms. Based on the symptoms, they'll know who to refer to. The default referral is always an audiologist, because once they get into an audiologist's office, the audiologist will know what needs to be done with that person. So that's triage level, or step 1. Step 2 is audiology services. So I just said the default level would be audiology services. That's what we're talking about right here. There are 4 questions that should be answered at step 2. Does the person have symptoms indicating the need for referral to another medical discipline? The audiologist will know if a referral is necessary. Does the person have hearing difficulties that would benefit from hearing aids? Audiologists have expertise in assessing and fitting hearing aids. Does the person appear to have a sound hypersensitivity disorder? This gets a little more complex, and there are many different, not many, but I have identified 5 different sound hypersensitivity disorders, and the patient needs to be at least screened to see if they might have a significant sound hypersensitivity disorder. I'll mention what those are in a moment. And does the patient desire treatment for bothersome tinnitus? Those are the 4 questions that have to be answered at step 2. So to answer these questions, the evaluation should minimally include a medical history, a hearing evaluation, screening for a sound hypersensitivity disorder, and assessing the patient for tinnitus-specific complaints. So the medical history, and I can't go into detail on anything, but I can kind of give you an overview. The medical history determines if there are any symptoms or conditions indicating the need for special services or referral to another specialty. Clinicians usually develop their own questions to interview patients to obtain this information. So there is no standard medical history. You can develop your own. And if you don't have one, a good resource to develop medical history questions is the American Academy of Otolaryngology Head and Neck Surgeries Foundation Guideline, Tunkel et al., 2014. I refer to them as the AAOHNSF. And they have recommendations for performing a targeted history. And I'm going to summarize what they recommend on the next slide. And I go into detail on these 2 books on medical history for TRT and for PTM. So I'm just going to list these out. If you have a patient and you're doing a medical history, you need to ask about sudden onset of hearing loss. Do they have unilateral tinnitus, pulsatile tinnitus, recent onset tinnitus, meaning has it been within the last 6 months, or is it very recent, within the last few weeks? Have they had significant noise exposure? Have they taken medications or had potential ototoxic exposures that could be the cause of the tinnitus? Do they have dizziness or vertigo? Do they have symptoms of depression or anxiety? Do they have apparent cognitive deficits? Do they have insomnia? Do they have migraine headaches, or do they have migraine symptoms? Have they experienced a traumatic brain injury? So that's the medical history. Hearing evaluation is straightforward. Most of you who are in this symposium are audiologists, and so I don't need to talk about a hearing evaluation except to just mention that many patients with tinnitus have sound tolerance problems. They might not do well with loudness discomfort level testing, and we generally don't recommend LDL testing. And also reflex testing may be uncomfortable for them. So if a person has tinnitus, you always want to check to make sure that when you're presenting any louder sounds that they're going to be comfortable with them, and otherwise let them know and get their permission to do that testing. And then screening for a sound hypersensitivity disorder. This could be referred to globally as hyperacusis. People talk about sound tolerance complaints, disorders. It could be referred to as many different things. I choose to call them sound hypersensitivity disorders. So what are they? Here's 5 possible sound hypersensitivity disorders. 2 of these are hyperacusis. And I learned fairly recently that hyperacusis isn't just hyperacusis. There's loudness hyperacusis and there's pain hyperacusis. Loudness hyperacusis is physical discomfort due to fairly low levels of sound that most other people find to be completely comfortable. Pain hyperacusis is distinguished because it's sharp, stabbing pain. There's actually pain receptors in and around the ear that can be causing that. There's other reasons, but it's a different animal than loudness hyperacusis. Loudness hyperacusis can usually be treated with a sound desensitization technique, whereas pain hyperacusis cannot. So pain hyperacusis needs a different treatment approach. Then there's misophonia. Misophonia is not physical discomfort, it's emotional reactions to sound. This is usually reactions to nose and mouth sounds, chewing, sniffing, coughing, sneezing, but it can be other things too. Misophonia is it's like a psychological problem. It's not a problem of the auditory pathways. Same with noise sensitivity. Noise sensitivity is an emotional problem where people are just annoyed by sound in general. They have a general problem with sound. They don't like sound, they avoid sound, they stay away from sound. That's very different from misophonia. Phonophobia is an irrational fear of sound. They're not reacting to sound, but they may have one of these other disorders. They are afraid that sound is going to be too loud, and they overcompensate by protecting their ears, wearing earplugs, wearing earmuffs, avoiding sound. They avoid sound all one way or another, and that would pretty much define phonophobia. So that's more of a psychological problem also. So these are the 5 possible sound hypersensitivity disorders. I'm writing about that now. I'll have a whole book available on it sometime this winter. And then assessment of tinnitus-specific complaints. What do I mean by that? How do you evaluate for a tinnitus-specific complaint? Well, in general, you need to ask questions to your patient about effects of tinnitus that cannot possibly be confused with hearing problems. We discovered that early on in our research that when we thought a patient had a problem with tinnitus, they were often blaming their hearing difficulties they were blaming their tinnitus for their hearing difficulties. So they had a hearing problem. They didn't know they had hearing loss, but they did know they had tinnitus. So they naturally blamed their tinnitus for their hearing difficulties. So that's generally not the case, and they need to be evaluated separately for their tinnitus-specific problems and their hearing-specific problems. Now, you can come up with your own questions, but we've already done that. I don't know that anyone else has done it, but I'm not recommending specific procedures, but I can say that the Tinnitus and Hearing Survey can accomplish this issue. The tinnitus section addresses tinnitus specifically, reactions to tinnitus that would not be confused with a hearing problem. We get a score for that section, and then we evaluate their hearing issues, which would not be conflated with any tinnitus issues, and we get a score for that section. This information is critical at the initial evaluation to know, are they really bothered by their tinnitus, and if so, how much? Are they really bothered by hearing problems, and if so, how much? And you compare one to the other. We also screen for a sound hypersensitivity or sound tolerance problem. And if you're really familiar with those 5 different methods, you have them fill out these 2 items or respond to these 2 items, and you will have a good idea whether you think they have a significant sound hypersensitivity problem or not. And then that would require further services to address those problems. Okay, and then a hearing aid assessment and fitting, that's something all audiologists know how to do. And then additional measures if needed for a step 4 method of counseling. So we haven't gotten to step 4 yet, we're in step 2, but what if you are a TRT clinician? You want to do specific additional measures for TRT. Like, for example, TRT recommends doing LDL testing. So you would do that at step 2. Now, we do not recommend it for PTM. So each of these methods has specific measures that they require, and those would need to be done at level 2 if you think the patient may need to move on to receive one of these counseling methods, or in particular, the one that you do in your clinic. So summarizing step 2 procedures, I put together this decision tree, and this can be helpful in the clinic. It's just straightforward. It's just if this, then this. These are the 4 things that need to be done for any patient who complains of tinnitus. Do a medical history, evaluate their hearing, screen them for a sound hypersensitivity disorder, and assess them for tinnitus-specific complaints. We haven't talked about a tinnitus questionnaire, such as the tinnitus handicap inventory, the tinnitus functional index. We don't recommend that, or I don't recommend that at this step, because you may not need to spend that much time with them. They may be blaming their tinnitus for their hearing difficulties, for example. So these 4 things need to be done, and based on these 4 measures or evaluations, you will know if a referral is needed, and you will know if treatment for the tinnitus seems warranted. Now, the additional testing I already mentioned. For example, they may need a hearing aid assessment. They may have significant hearing difficulties, and audiologists will naturally do a hearing aid assessment. Or you may need to evaluate them for the TRT or whatever you might be doing as your tinnitus program. And if they have a sound hypersensitivity disorder, or they seem to based on the screening, then there are evaluation methods for these patients, for these different methods of treatment. So depending on what you do, you may have your own way of evaluating patients for a significant sound hypersensitivity disorder. Otherwise, these methods have specific procedures, and there are other methods also. So basically, they need to be followed up. If they screen positive for a significant sound hypersensitivity disorder and you think they really may have one, they need to be followed up appropriately. All right, and then if hearing aids are not recommended, then basically you want to know, is the tinnitus bothersome? If no, tinnitus services are complete. If yes, you want to know, are they going to need the next step in the Stepped-Care program. And the next step would be tinnitus education, step 3. And if they are going to do tinnitus education, you need to do a tinnitus questionnaire. And the reason is because we consider tinnitus education to be treatment for tinnitus. So if you're treating them for tinnitus, you always need to do an outcome measure before and after the treatment, and that includes education. Now, if you're fitting hearing aids, same thing. You want to know if the tinnitus is bothersome, but really you want to follow up with them a month or two later. The hearing aids alone may have been sufficient in resolving the tinnitus problems. And so it may be that tinnitus is not bothersome at that point and tinnitus services are complete. Otherwise, if the tinnitus is still bothersome, they've been wearing the hearing aids, they've done the follow-up, they're still bothered by their tinnitus, then the next step would be tinnitus education. And here's tinnitus education, step 3. Basically, patients need to be informed about what tinnitus is. That's what I wrote about in this book. That's the intent of this book. It's just an overview. What is tinnitus? Why is it a problem? How is it a problem? What can be done about it? Patients need that information. You can do one-on-one with your clinician, spend an hour with them, explain everything to them, answer all their questions. It can be done in a group setting. Some clinics like to do these educational sessions once a month, and they invite everyone to them. Sometimes they charge a fee, sometimes they just make it free, or by providing appropriate learning materials. Send them home with a book like this, send them home with a handout, materials that you've put together, whatever it takes to inform them about these basics of tinnitus so that they can make informed decisions in the future. And so the AAO-HNSF has made some recommendations for what kind of education patients needed. They said patients need to know what are the available management strategies for tinnitus. They should know what's the natural history and prognosis of tinnitus. What do most people do? What is the experience for most people? What's the association between hearing loss and tinnitus? That's critical for patients to understand. What are the effects of lifestyle factors on tinnitus management? What is their life like? Is it more conducive to being bothered by tinnitus where they don't have much to do, they're bored, they are in quiet environments, or are they busy? Are they in more noisy environments? What's going on in their life? And then hearing protection from noise, that's really critical. They need to know to protect their ears from loud noise. So following the education, patient completes outcome measures. Okay, remember I said education is treatment. So they need to be assessed for outcomes before and after the education. We recommend the Tinnitus Functional Index, but you can use any tinnitus questionnaire you like because most of them pretty much work well. And you're looking for a reduction in the score from pre-treatment to post-treatment. You want to know that the score is, say, decreased from 60 to 40 or 60 to 30 or whatever. Sometimes the education is all they need. They just need to be educated. However, we also recommend a global impression of change question. So ultimately, a change in the tinnitus questionnaire score between pre and post-treatment is less important than the person's impression if there has been improvement. So how do you evaluate that impression? Here's a question. Compared to before I started the treatment, my tinnitus now bothers me how much? Does it bother them more? Does it bother them less? How do they feel about the treatment and how it worked for them? And this is the most important way to assess outcomes. You still need that score and the change in the score between pre and post treatment, but you also need to ask this question or a question similar to this. And then we also like to ask about quality of life. Is their quality of life improved from compared to before treatment? It may not have anything to do with the treatment, but it also very well may. So these are the two questions we recommend. Just ask these two questions in addition to your tinnitus questionnaire. So then they've completed the education, you've done the outcome measures. Do they need step 4 tinnitus counseling? That would be the basic treatment level. Even though education is considered treatment, this is very directed treatment. And so the patient decides if tinnitus counseling is desired. And we've already talked about all of these different methods. There's established methods, there's mindfulness, there's ACT. And then again, you after you've gone through this treatment, it can be one-on-one, it can be group, it can be video, it can be telehealth, it can be any way you provide the treatment, or any provider provides the treatment. It may not be you, I mean, you may refer them on. But they need to be evaluated pre and post to see how well the treatment worked. And of course, there's many other methods of treatment. So there's apps. Apps can be the primary source of therapy, or they may complement another method of treatment. There's hearing aids. Hearing aids can have sound generators and streaming capabilities. A hearing aid is a very powerful sound therapy device. Psychologists and other psychological health providers are less commonly available to provide the tinnitus counseling. I mentioned that in my first talk. CBT has the strongest evidence for tinnitus treatment, but there's the fewest providers available to implement CBT. So there's also the possibility of receiving services remotely, and there are psychologists who provide CBT and third wave CBT virtually. And then the outcome assessment. So following the counseling, your patient repeats the outcome measures. So it should be a basic tinnitus questionnaire pre and post treatment, and then the global perception of change question or questions. That can be anything you put together. This is our suggestion. So was the counseling enough? And it usually is. I mean, if a patient has gone through steps 1, 2, 3, and 4, they've had all these evaluations done, they've had their questions answered, they've had the basic education, and they've had the counseling. So was that enough or not? And if not, then they need to be evaluated very comprehensively by both an audiologist and a psychologist, or possibly another specialist. And a psychologist is particularly important because they may have a psychological disorder that is the reason they can't seem to get over their tinnitus. Their tinnitus continues to bother them, but it may be because they have anxiety that is untreated, and so they need to be treated for the anxiety. Or they have insomnia that's untreated, and the tinnitus may exacerbate the insomnia, but the tinnitus is really not the primary issue. The insomnia is the issue. So anyway, a lot of possibilities of why all the services they've received have not been sufficient. They may have been non-compliant with the treatment recommendations. They may not have attended all of the counseling sessions. They may want their tinnitus cured and nothing else will do. So we have people like that. They come in wanting a cure, and no matter what you say to them, you tell them you can improve their life, you tell them you can help them to sleep better, concentrate better, not react so much to their tinnitus, they don't care. They want their tinnitus gone, and nothing else will work for them. So they may go through all these different levels, and they still want their tinnitus cured, and that's all they want. So anyway, these are some reasons why patients may need further services. Now, if they do need further services, they can move on to step 6, expanded treatment. This just opens up all the possibilities for treatment. All the things we've been talking about in my intro session, all these experimental methods, bimodal therapy, bimodal stimulation, different apps, different devices. There's so many different treatments out there. I would say this opens it up to all of them. Provided you think the treatment might help them, it's appropriate for them, they can afford it, and it's safe to use. They can try just about anything at this point, and they may have their mind set on something. You know, they saw an ad for a particular treatment, and that's what they want, and nothing else is going to work for them unless they get that treatment. So anyway, That's step 6, expanded treatment. Okay, well, so that's basically it. I've run out of time. We've just talked through all these 6 different steps, 1, 2, 3, 4, 5, 6. It's a framework. It's not specific procedures. Now we can suggest specific procedures within each one of these steps. What the idea is for you to do whatever you do within this framework. That's what I'm suggesting. And if you do it within that framework, it makes it easier to compare between different clinics. So you're doing TRT, somebody else is doing PTM, somebody else is doing CBT. But if you're all doing it within this framework, you can compare outcomes, especially if everyone would agree on a common outcome measure or set of outcome measures. If nothing else, the Global Perception of Change question is one good question to find out how well your treatment worked. So I will end it once again, as I did for my first talk, with this quote from Languth et al., 2023. The ultimate goal is to help the tinnitus patient. Clinicians should have the leeway to choose appropriate treatment, even if the quality of evidence is low, which is the case for most treatments. A holistic approach that considers all factors should be used in making clinical decisions. So I'm going to stop there. I thank you once again for participating, and hopefully you are getting a lot out of this symposium. And feel free to contact me if you have any questions or if there's anything I can do to assist you in your being a provider of tinnitus and potentially different sound hypersensitivity disorders. So thank you very much, and look forward to seeing you and talking to you in the future.